Hello, welcome to Quality Improvement Imperatives for the Rural Health Clinics. I'm Jill Osterly, Director of Provider Solutions at the Michigan Center for Rural Health. Thank you for having me here today. I'm excited to be here and share the great things that are happening in Michigan. This presentation will discuss quality improvement programming barriers and share strategies to support the shift to planned quality improvement. At the end of this session, attendees will be able to describe the 4 key areas of a Plan, Do, Study, Act, and also recognize the barriers and solutions to quality improvement programming. First, a little bit about the Michigan Center for Rural Health. We were established in 1991, and we are the designated state office of rural health for Michigan. All 50 states have a state office of rural health, varying in size, scope, services, and the resources they provide. Michigan is a bit unique. We are one of only 3 nonprofit state offices of rural health, where other state offices are located within the state health departments and/or universities. As the State Office of Rural Health, the Michigan Center for Rural Health helps to create partnerships among various organizations and create new opportunities, strengthen the healthcare delivery system in those rural communities. Our program areas include hospital programs, primary care, veterans care, emergency medical services, workforce development, social drivers in health, and the Northern Michigan Opioid Response Consortium. As you can see by the slide, we have a small but mighty group. A little bit about me. I joined the Michigan Center for Rural Health in October of 2017. I just celebrated my 6th year anniversary. But before that, I was a practice manager at a small critical access hospital called Eaton Rapid Medical Center, and I managed 2 of their certified rural health clinics. This, without a doubt, was the most challenging job I have ever had. I also spent 24 years at a larger tertiary facility called McLaren Greater Lansing. All these positions prepared me for what I'm doing today. In addition, I am a trained practice facilitator. I've received my CRHCP certification, which stands for Certified Rural Health Clinic Professional. That certification comes from the National Association for Rural Health Clinics. So knowing what I know about rural health clinics, I'm excited to be able to share that with you today. A little bit more about my role. My role is to manage all aspects of the rural health clinics in our state. We currently have 221 RHCs across our great state. I also provide support and facilitation for our rural health clinic network. My passion is rural primary care, providing that technical assistance around regulatory and compliance to these offices as well. But most importantly, I really enjoy helping them build that clinical quality structure and capacity in their clinics. A little bit about our network. The RHC Network Initiative started in 2011 with a small group of dedicated rural health clinic practice managers. Their goal was, and still is today, to provide a way to measure and improve the quality of care of Michigan RHCs. The RHC network is a member-driven and governed by an executive board. We support this work through our federally funded Flex grant. The network meets quarterly, either virtually or in person, and the content of each of those meetings is standardized but pivots when necessary to meet the needs of its members. Typically, we talk about national updates, compliance and regulation. We always include a quality improvement component and then peer-to-peer sharing and networking. I attended these meetings when I was a practice manager and found them of a huge value. The RHC network was modeled after the Michigan Critical Access Hospital Quality Network, known as MICA. MICA was the network that worked on the MB-QIP program. For those of you who aren't familiar with MB-QIP, MB-QIP is a quality improvement activity under the Medicare Rural Hospital Flexibility Program, known as FLEX. MB-QIP aims to improve the quality of care provided in critical access hospitals by increasing the quality data reporting by cause and then driving that quality improvement activities based on that data. With such great success, it made sense for us to model our RHC network after the MICA Quality Network. Oops, sorry about that. As we know, federally qualified health centers and certified rural health clinics are extremely important safety net providers in rural and underserved areas. FQHCs and RHCs are different when it comes to quality reporting. FQHCs have a heavy lift and they are required to report on performance measures, unlike RHCs, which are not mandated to participate in or report on value-based programs. Here's what we know. Quality improvement activities are becoming standard practice in all of primary care. However, just because RHCs don't have to report, that doesn't mean they are exempt from the wave of national efforts to create a high-value healthcare system. Experts agree that quality metrics will eventually be introduced for the rural health clinics, and payment structures could be tied to these metrics. While the timeframe for these potential changes is unknown, CMS has already moved away from paying for the quantity and towards paying for quality of care. Additionally, beginning in April of 2021, encounter-based payments for new provider-based RHCs were capped. This contrasts with the previous cost-based reimbursement. Lastly, many of our payers have moved to a pay-for-performance type of program. The pay-for-performance incentive rewards providers for delivering quality healthcare services. Most of you probably equate this to your HEDIS program or closing those gaps in care. This is something clinics need to understand because money can get left on the table if they don't participate in these programs. I don't need to convince you that quality improvement is essential. However, creating or making your quality improvement program more robust is more important than ever. So understanding and properly implementing a quality improvement program is essential to a well-functioning practice and is necessary for any practice interested in improving efficiency, patient safety, or clinical outcomes. When preparing for this presentation, I found a statement from the Centers of Disease Control and Prevention, and I want to share it with you all. It states, quality improvement is defined as a continuous and ongoing effort to achieve measurable improvements in the efficiency, effectiveness, performance, accountability, outcomes, and other indicators of quality in services or processes which achieve equity and improve the health of a community. So again, the Centers for Disease Control and Prevention defines quality improvement that way. So we know there are a number of challenges around quality improvement. I want to share a little bit of them with you today. First and foremost, building and sustaining a quality improvement program is not easy, but it doesn't have to be hard. Some of the challenges you'll face include knowledge of that quality improvement structure and what those interventions are, inadequate staffing, a lack of time, difficulties in that data collection. Every EHR is different and it has its own unique pros and cons. Finally, there's a lot of resistance to change and competing priorities from your staff. I know firsthand experiencing that from your providers, and gaining providers and staff engagement and quality improvement can be tough. As part of my work for the Michigan Center for Rural Health, several months ago, I was invited to assist a group of RHCs. I was asked to provide education and resources for our cardiovascular quality improvement efforts. I was really confident in the information I had to deliver and that it was valuable and timely for them. I could assist with their QI project. I had already been trained as a practice facilitator and had been doing this type of work for over a year, so I felt really confident. As we sat down for lunch, the entire team, 2 physicians, a PA, MAs, and receptionists, were there. You could tell there was quite a bit of hesitancy and most likely some resistance and probably a little bit of annoyance. Nonetheless, I forged forward. I got about 2 sentences out and the doctor said, "Stop." Needless to say, he did not want to hear anymore. And he shared his frustrations over all of the challenges that they have and that they face every day. As he was explaining some of the things around his patient panel, around some of the barriers, I began to chip away at that and sharing with him what are some of the things that I can bring to him. And it wasn't about adding more to his plate. It was about helping them do the work that they're already doing more effectively. As I shared the resources, he started to change his demeanor. And by the time I left, I promised him a list of resources, and he was grateful that I was there. This, without a doubt, is going to be something that you experience, and know that this is a challenge that we have to face, and knowing that we can help our providers do the work they're already doing more effectively is your first step. Even when practices recognize the importance of improving their performance or are financially incentivized to do so, they may not know where to begin quality improvement activities, and they don't know what they don't know. So a few basics as you begin your quality improvement journey. You want to establish a culture of quality in your practice. The QI culture looks different for every practice, but may include establishing dedicated QI teams, holding regular QI meetings, or creating policies around your QI goals. You also want to determine and prioritize potential areas for improvement. You will need to identify and understand how your practice could improve. You want to examine your patient population, understand where your barriers to care are. What are your frequently diagnosed chronic conditions or groups of high-risk patients? And your practice operations. What are your management issues? Is there low morale? Is there long patient wait times? Poor communication? Use established quality metrics to guide your efforts. Know where you're at on your dashboard. Collect and analyze your data. Data collection and analysis lie at the heart of any quality improvement effort. Your data will help you understand how well your systems work or don't work, identify potential areas for improvement, set those measurable goals, and monitor the effectiveness of change. It's important to collect baseline data before you begin any quality improvement project. You must commit to regular data collection, carefully analyze your results throughout the project, and then make decisions based on your analysis. You also want to make sure you communicate your results. Quality improvement efforts should be transparent to your staff, your physicians, and even your patients. Include the entire practice team and patients when planning and implementing quality improvement projects. You want to communicate your project needs, priorities, and actions, and the results to everyone, again, including your patients. When a project is successful, celebrate and acknowledge that success. Also commit to ongoing evaluation. Quality improvement is a continuous process. It's not a one and done. And last, spread your success. Share the lessons learned with others to support that wide scale, rapid improvement that benefits all patients and the healthcare industry. What are some of the benefits to quality improvement? Even though there are challenges, there are also opportunities and unique benefits to quality improvement programming. It can help you prepare for the transition to value-based payment models. It can help you have greater success with programs such as PCMH, your ACOs, your chronic care management, your transitional care management, your Medicaid managed care programs. You can participate in public reporting of physician quality data, and more patients are reviewing this information. So you want to be able to do this. Participate in federal quality improvement programs such as QPP, and it also helps equip you with the skills necessary to apply for and compete in national programs that you can get recognized for your great work. A little bit about value-based programs and the care that they focus on. Provider payment incentives that reward value rather than volume. Provider payment incentives that reward value rather than volume. Models of care delivery that coordinate and integrate clinical services for patients and communities, focus on prevention and wellness. Value-based care focuses also on information sharing, creates that transparency on the cost, quality of care to support better decision-making by the providers and consumers. Value-based care also focuses on providing care based on value instead of volume. And it is proven difficult for rural communities due to their smaller size, lower volume of patients, and financial vulnerability. And they're also subject to specific statutory requirements and are not always included in some of these new incentivized initiatives. However, rural providers have shown that they can match and sometimes exceed the performance of those urban providers, and can also benefit from greater efficiencies, different incentives, and improved quality of care that value-based care initiatives require. Again, greater success with programs such as PCMH, your ACO, CCM, and Medicare, Medicaid programs. With the assistance and facilitation from their source, RHCs can take part in this critical work. So one of the tools that I want to first introduce to you is the Plan, Do, Study Act. You can use this within your quality improvement programming. I want to go back to the Centers Disease Control and Prevention and their definition, because I think it really, really relates to this Plan, Do, Study Act. Again, they define quality improvement as a continuous and ongoing effort to achieve measurable improvements in the efficiency, effectiveness, performance, accountability, outcomes, and other indicators of quality in services or processes which achieve equity and improve the health of the community. As I was preparing for my presentation, I Googled PDSA. Needless to say, there are several reputable websites that fully explain and outline the PDSA model. So I don't want to spend a ton of time on it, but I do want to equate the CDC definition to what a Plan, Do, Study Act is, because they really mirror each other. A PDSA simply is a framework that can assist you with your quality improvement efforts. It's easy to adopt regardless of your practice size or your amount of resources. So what are the 4 steps? Plan, Do, Study, Act. Going through these 4 steps guides the thinking process into breaking down the tasks into steps. Most of us go through some of these or all these steps when implementing a change, and we don't even think about it. For instance, when you go on vacation, you just don't go on vacation. You plan your vacation. You plan where you're going to go. You plan what you're going to do. You plan how much it's going to cost you. You plan how you're going to get there. And then you go on vacation and you do everything that you planned. When you get back, you think about your vacation. You think, well, I really probably shouldn't have taken the train. It took way too long to take the train. And you look at the successes of your vacation versus some of the areas that, yeah, I think I would change this next time. And the next time you go on vacation, you act on the things that you learned. That's your PDSA. That's what we do in healthcare and can do in healthcare. You can plan, do, study, and act. So a little bit about the first step. Let's break down the different steps. Again, step 1 is plan. This is where you develop the plan and what step you will take to make an improvement. As you begin to develop your plan, you might ask yourself these important questions. Where does your practice need to improve patient care? It's the first thing you should ask yourself. Your practice might already have some performance measure data. Take a look at your dashboards, your scorecards, your EMR reports. Where's your practice less efficient than it should be? Again, your team may be able to identify bottlenecks in the workflow. If you've never done a PDSA, it's excellent to prioritize those areas where you have some control over and that your team will think is the most impactful. Make sure you can answer, what's in it for me? This can impact the staff perception of the project. Maybe it's a bottleneck in patient registration that compromises the schedule frequently. They will have buy-in for that type of project. Who should be on your PDSA team? The people doing the PDSA or the people doing the work should help you plan and guide the process improvement initiative. Your PDSA team should include representatives from all of your areas of your practice that will be affected by this improvement. You also want to make sure you make SMART goals, goals that are specific, measurable, achievable, and realistic. Your quality improvement team should work together to develop this plan, and the plan is created to test and improve your identified process. Step 2. This is where the fun begins. You get to implement your plan. Once you have your plan, it's time to put those action steps into motion. A couple of key things to consider. Make sure you communicate the new process to your team. Keep things positive. Share inspiring stories to keep everyone excited about the change. You want their engagement. You might even consider starting small by piloting the improvement with one physician and MA team or in one pod. This can help an initiative gain that traction and allow the PDSA and those pilot teams to work together to implement the new process successfully. Ensure you and your staff document their observations and keep track of problems and unexpected findings. You will use this information in the analysis phase. After the change has been implemented, regularly discuss the adoption of the new process at huddles and meetings. This will help you determine if the change actually had the desired result. Step 3, study and analyze your results. You may discover that your change has been very successful, or you might find that you're not seeing the improvements that you expected. Your team should consider all factors that might have contributed to the findings. So again, go back and look at some of that information that you documented while you were in that do phase. And the last step is act. This is the point where you decide to either adopt, adapt, or abandon that process. The PDSA cycle is meant to be continuous, and even your best processes can be improved and become more consistent. You can further refine your process by repeating that cycle. Repeat the cycle an entire time to be able to refine and get greater improvement. You really want to celebrate completing your first PDSA cycle, even if it didn't result in the improvements that you were looking for. You can view this as a learning opportunity. Also, present a summary of the report during a lunchtime meeting and/or celebrate your successes through communications, through a brag board. Post an overview of the effort on a bulletin board in a common area. Those are all great ways to be able to share your success. So that's your PDSA model and the 4 steps that are included. So moving forward, I wanted to share a few thoughts about moving forward with quality improvement structure and capacity within your clinics and your healthcare systems. Developing that internal QI capacity contributes to the ability of RHCs, FQHCs, and hospitals to improve quality in patient and provider experience and reduce cost. Financial and non-financial incentives, we know, play a crucial role in encouraging the development of this capacity. And ultimately, practices should reach the point where ongoing QI efforts become part of their policy and procedures. We know policymakers and payers can consider ways to promote and support the development of QI practice or QI capacity in primary care, and we know that's already happening. I want to share a few external supports with you. I know not all of you have a robust quality improvement structure within your clinics, but external support organizations can really offer assistance to build and sustain that quality improvement capacity in a meaningful and systematic way. There are some examples of the external organizations that support practices in that undertaking of quality improvement activities. These organizations are state offices of rural health, your physician organizations. PCMH often has practice transformation coaches, your AHACs, your accountable care organizations, your QIOs, your practice-based research networks, your primary care associations. These are all organizations that can assist you in your quality improvement structure and capacity. So now is the time to let your RHC shine. One of the things that I love to be able to reflect on are the lessons learned from the COVID funding. RHCs, for the first time ever, received COVID funding via a grant. RHCs have never received grant funds like that before. FQHCs typically have, but now looking at our underserved communities, really tag teaming with RHCs and FQHCs and counting on some of those resources is paramount. We want you all to capitalize on the QI funded opportunities that are out there. So I do want to share a couple of resources with you, actually more than a couple. These are some funding and resources that you should think about and potentially engage in. The RHI Hub, if you've never used this database, it's fantastic. It's a searchable database that lists rural funding opportunities. The Robert Wood Johnson Foundation, again, great funding opportunities. Every state has a different Medicare or Medicaid managed care organization. There's resources by states, USDA, Blue Cross Blue Shield Foundation. Every state has different funders. Make sure you know who they are. Make sure you know how you can capitalize on that. SAMHSA, Connected Nation, Your Federal Office of Rural Health Policy newsletter. They always have funding opportunities in there. The National Consortium of Telehealth Resource Centers, again, a great resource. Your National Rural Health Association newsletter, your National Association for Rural Health Clinics, National Kidney Foundation and the American Heart Association are two relatively new ones that I've listed on here, but they are a wealth of information. These are all funding and resources that you really should consider. I've included all of those resources on my resource and reference page. They're all hyperlinked in this presentation. Feel free to click on them and learn more about these organizations. Again, a great opportunity to advance the work, the great work you're already doing. My contact information is on the slide. Feel free to reach out to me with questions, and I hope you find this information valuable. Thanks again for joining today.